So I'm going to be talking to you about hypertension, and it's related to intracranial pressure. And the problem is these two things are very closely related when we see the patient. And patients who have symptoms of increased intracranial pressure, those symptoms overlap with malignant or hypertensive emergency. And so it's really important to try and differentiate these two, both on clinical grounds, radiographic grounds, and then on a spinal tap, because patients who have severe headache often have elevated blood pressure, and patients with elevated blood pressure often have headache. And so you cannot use this headache alone to differentiate whether we're dealing with increased blood pressure or increased intracranial pressure. And for ophthalmology, as you know, the grading system, 1, 2, 3, 4, the cut point is grade 3, determining end organ damage. You're going to have arterial narrowing for grade 1, hypertensive retinopathy. Grade 2 is the AV nicking. Grade 3 is where we're getting the hemorrhages, the exudate, and the infarcts, the cotton wool patches. And then grade 4 is defined as optic disc edema. And the problem in the literature is the use of this word, papilledema, for grade 4 hypertensive retinopathy. We in Neuro-Op reserve this term for disc edema related to increased intracranial pressure. And so we are trying to differentiate, am I dealing with optic disc edema from hypertension, or am I dealing with increased intracranial pressure related optic disc edema, papilledema? So when we look in the eye, we can normally tell the difference between hypertensive retinopathy and papilledema, because the hypertension is an arterial disease, and that causes all the findings that we see in the grade 1 through 4 hypertension. We're going to see arteriolar narrowing because there's going to be thickening of the wall to account for that chronic high pressure. The AV nicking changes are where the artery crosses the vein at its common adventitial sheath, making it look nicked. And then the leakage from the destruction on long-term damage of the endothelium to the blood-retinal barrier that leads to the hemorrhages, exudates, and the cotton wool spots. In contrast, papilledema just is at the disc head. So when you have increased intracranial pressure related disc edema, all the action is at the disc head. And so when we see the disc, we can grade the disc using the Friesen scale. And in the Friesen scale, grade 1 is a C-shaped halo with preservation of this temporal portion of the disc. It's a nasal elevation. And that's grade 1. In grade 2, it'll be a 360 degrees of elevation. In grade 3, we'll have obscuration of the vessel, the major vessel, as it's crossing over the margin. And in grade 4, central vessel gets obscurated from the neurofibrillary edema. So if we can grade the disc edema, Friesen 1, and there's no other evidence of grade 1, 2, or 3 hypertensive retinopathy, this patient, even if their blood pressure is elevated, is going to be much more likely to be papilledema and a lot less likely to be hypertensive grade 4 retinopathy. The problem is these two things are interrelated. And if you do spinal taps on patients who have hypertensive emergency, a lot of them, maybe a third or more, have elevated intracranial pressure as well. And so we have to treat both. And the reason is, even though it's called hypertensive retinopathy, I don't believe that the retina is the end organ that they have in mind. The end organs that we have in mind as the defining criteria for hypertensive emergency are kidney, heart, and brain, not the retina. The retina is just showing us the brain problem. And the brain problem is what drives the decision making to admit or not admit, because hypertensive emergency is an admission and hypertensive urgency is an outpatient evaluation. Hypertensive emergency needs to have reduction of the blood pressure, probably not more than 25% in the first 8 hours. And you got to be aware that there's been a shift in the autoregulatory curve in hypertension that's long-standing. So normally we have good autoregulatory capacity within a very wide range of blood pressure against cerebral blood flow. But once that number gets too high, we lose the autoregulatory capacity. And that's what produces the hypertensive emergency. In chronic hypertension, the whole curve is shifted to the right. And that means if you lower the blood pressure to a number that you think is within normal limits, if that number is on the steep part of this guy's curve, you'll cause ischemic optic neuropathy or a stroke. And so the way to differentiate hypertensive from intracranial pressure-related disc edema is three things. Number one, talk to the patient, get the history, the symptoms. If they have symptoms of increased ICP, you cannot use the headache, but transient visual obscurations, pulse synchronous tinnitus, and the diplopia from the sixth nerve palsy, these suggest increased ICP and not increased BP. We're going to look at the MRI in this patient, and what we're looking for is the radiographic findings of increased intracranial pressure, fluid in the sheath, flattening of the globe, venous sinus stenosis but not thrombosis, empty sella. If we see those features, those are not features of hypertensive disease. Those are the features of increased intracranial pressure. And the only way to measure this pressure is to do a spinal tap. And if the intracranial pressure is high on the spinal tap, we would recommend that you treat it for both blood pressure and increased intracranial pressure if we see the disc edema. Because sometimes you have both.